Hello, I'm Bob Chaloner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, your monthly program about the events, happenings, and people at your local community hospital. Today we have a very interesting and what I would consider high-tech presentation. We have a new program at Southampton Hospital based in our brand new Audrey and Martin Bruce Heart and Stroke Center. And leading our efforts is a new physician to our community who's joined us from Stony Brook. His name is Dr. Apostolos Tassiopoulos. He's a chief of vascular surgery at Stony Brook. He's a surgeon and he's a professor of medicine and surgery at Stony Brook University. And Dr. Tassiopoulos, or Tass as we call him here at the hospital, I think your name has more letters in it than any other human being I know. We'll be talking about some of the very advanced vascular work that we're doing at the hospital. So welcome, Dr. Tassiopoulos. Nice to see you. And,
nice to be here.
And as I always like to start off, I like to know a little bit about, and I know the viewers would like to know a little bit about you. And tell me about your training background and how you ended up here in Long Island.
Sure. I was born and raised in Greece, and I finished medical school in Greece at Aristotle University. Soon after that, and after I completed my military service as a physician, I came to the U.S. Wanting to train in vascular surgery. At the time, Europe did not have a pure training program for vascular surgery, and of course, the U.S. had an established training paradigm since the mid-'80s. I started with a year working with Dr. Michael DeBakey at Houston at Methodist Hospital. And I did my general surgery training at upstate New York in Syracuse. Okay. I joined the Vascular Fellowship Program at Loyola University in Chicago with some of the more prominent surgeons of the time, Dr. Bill Baker and Dr. Fred Litui. And I was fortunate enough to catch the transition of traditional vascular surgery to the new era, to the modern era of endovascular surgery at that time. I took my first job in Chicago. I worked for Rush University, and I developed an endovascular program at the newly built Cook County Hospital. But 4 or 5 years later, I was ready for a new challenge. I wanted to advance my academic career, and I was approached by the chairman of surgery at Stony Brook at that time, Dr. John Ricotta, to join their team. Okay. And 2 years later, I became the chief of vascular surgery here.
Great. Well, interesting question. Vascular surgeons are trained differently than general surgeons, and it's also often additional education on general surgery.
Correct.
Why does it require specialization?
Well, over the years, that need has changed. Okay. When I started my training, the idea was to train somebody for the more complex components of open vascular surgery, okay, carotids and aneurysms. In recent years, that need has become even more apparent with the need of training vascular surgeons to the new endovascular techniques. That training by itself is a totally separate training on top of the traditional vascular surgery, so it does require an extensive period working with a specialized vascular team. Over the years, we have a complete divergence between the general surgery training and the vascular training, to the point that as of 2006 now, we have programs that train independently, okay, vascular surgeons with a minimal component of general surgery to their training.
Because the focus is so much the vascular system.
Completely different right now.
And just because many of the people watching are lay people and sometimes have trouble understanding all the various specialties in medicine, when we say a vascular surgeon, the part of the body that you're operating on, could you just describe that for people?
We're essentially operating on blood vessels in the entire body with two exceptions, okay, the intracranial vessels, okay, and the vessels of the heart.
Okay.
every other blood vessel, artery, or vein in the body is essentially in the treatment spectrum of a modern vascular surgeon.
And there are a number of diseases I know, and we'll be talking about the repair of aneurysms, which is a particular area, very critical disease of the vascular system. Before we do that, though, I know that we have some new technology at Southampton Hospital, our new hybrid room. And that was one of the things I know that attracted you to come work with us here at Southampton Hospital. Can you talk a little bit about that technology and the Heart and Stroke Center and why this is important technology?
Sure. The majority of vascular interventions nowadays are image guided.
Okay.
We utilize different types of imaging, including ultrasound, intravascular ultrasound, the traditional fluoroscopy, which is the plain X-ray, digital subtraction angiography, to guide ourselves to the area of problem and treat that area either with open or endovascular techniques.
Mm-hmm.
Over the past 20 years, we have developed a wide spectrum of endovascular techniques in managing common and complex vascular problems. The quality of imaging plays a tremendous role in our ability to treat these conditions. What we have in Southampton nowadays is we have perhaps the most advanced hybrid operating room in the entire greater New York area.
In the entire region, really.
We have the latest and most advanced imaging technology in terms of fluoroscopy in the setting of an operating room that has every capability of supporting an open or an endovascular procedure. The imaging system is not only great in terms of the quality of images that it provides, but it has unique software that allows us to merge preoperative images with intraoperative images and create very sophisticated roadmaps in terms of navigating our instruments and treating accurately and effectively the conditions that the patient may have.
I would think the imaging would be critical when you're talking about spaces and vessels that are really quite small, and trying to operate without actually opening somebody up to see them. It's got to be a very, very difficult challenge, and I can see why the imaging would be so important.
Correct. I mean, the body has a tremendous number of blood vessels that differ by region in size, and also their access from a remote point requires specific navigational skills, but also advanced imaging, as we said, so that you can always know where your catheters or wires are navigating and how does your patient respond to all of that.
Right.
The imaging is a very critical component on anything we do these days, and having an advanced system like what we have at Southampton Hospital not only helps the doctor, but helps the patient. It minimizes the amount of radiation, it minimizes the amount of contrast that we need to utilize, and makes these procedures more accurate and safer for the patient.
Fascinating. And I know one of the areas that you in particular have done quite a bit of work on and already done a number of cases here at Southampton are aortic aneurysm repairs. But before we even, it's interesting because lots of parts of the body, everybody seems to know the kidney, the liver, the stomach.
Correct.
And then we've got these parts of our body like the aorta, and we hear about aortic aneurysms. Let's do some real basics. Tell me about the aorta. What is the aorta?
Sure. The aorta is the biggest artery of the body.
Okay.
It starts at the heart, travels upstream to give the neck vessels, and then downstream in front of the spine all the way to about where our belly button is,
Okay.
where it splits into the two arteries that provide blood flow to the pelvis and to the lower extremities.
Okay.
So it's a long vessel ranging in diameter between 1.5 inches and 1 inch at the lowest part.
Really?
An aortic aneurysm is anything that exceeds double the size of the aorta at that particular level.
Okay. And an aneurysm, just for the lay people?
It's a
among us?
ballooning out of the artery,
Okay.
essentially a dilatation of the artery that can be focal affecting only one part of the artery, or it can be pretty diffuse and affect the entire part of the artery.
Okay.
Now, traditionally, we treated aneurysms with large open operations. I remember my training years where most of these patients were treated open. We had to make big incisions, require the patients to stay in the hospital for a good 7 to 10 days before they get discharged. And they were out of work and out of their regular activities for a total of about 2 to 3 months.
Right.
We've come to the point that we can do these procedures now completely percutaneously without making any incisions. The whole process takes anywhere between an hour and 2 hours, depending on the complexity of the procedure. Patients go home the very next day, and within 2 weeks, they're back to their regular activities. So a dramatic improvement on the way that we treat these problems over the past 15 to 20 years.
And the way I've sort of heard it explained and tried to think about it, if you think about a hose and a hose starts to burst get a weakening in the hose, and the hose sort of balloons out in a spot, and the old way would have been to wrap something around the hose to strengthen it, and now you're going essentially from the inside out, right, to strengthen it? That's the way this procedure works?
That is quite accurate.
Okay.
I think that the analogy with a hose and a ballooning out of a certain segment that is weaker than the rest of it is definitely exactly what an aneurysm would look like. In the old era, we would, and actually for some patients even right now, we essentially resect, take out that part that is weak and dilated, and sew in between an artificial graft that bridges the gap that we create.
Okay.
As you described, the endovascular procedure involves inserting something inside the blood vessel and creating, so to speak, a new lining that doesn't allow the blood pressure to transmit to the weak part of the wall, but rather to the graft that we put inside. And that way we protect further enlargement and rupture.
And just so we understand the danger of an aneurysm, what happens and what are the repercussions with an aneurysm?
The unfortunate thing about aneurysms is they don't give symptoms.
Okay.
They can grow to really large sizes without creating any pain or discomfort.
Really? Wow.
The majority of them are found incidentally in studies in ultrasounds or CAT scans that are done for a totally different reason, and suddenly you get this big surprise. The risk with an aneurysm is related to its size. An aneurysm that exceeds 5.5 centimeters in diameter, which is about 2 inches, starts having a significant risk for bursting.
Okay.
And bursting results in internal bleeding, and that in more than 50% of the patients causes instant death.
Instant
or
death, really?
within very few minutes.
Okay.
Another 50% of the patients will have what we call a contained rupture and will be able to make it to a nearby hospital facility.
Okay.
At that time, they feel pain, they may have, they may faint, they may collapse, they may have back pain. And out of these people that reach a medical facility and can be treated, 50% will probably die as results of the complications of the rupture.
Really?
This percentage in recent years has started getting better with the availability of endovascular techniques. Being able to fix a burst aneurysm with endovascular means decreases the degree of complications that these patients develop around the time of the operation and improves their survival.
So clearly something that can happen quickly, no warning signals. It would be important to know risk factors. So who should be concerned? I mean, are there specific groups of people, and what are the risk factors for developing it?
Age is one of the risk factors. Aneurysms are pretty rare before the 6th decade of life.
Okay.
Male
And
patients,
why is that? Is it just as we get older, our arteries are...
our arteries tend to degenerate a little bit more.
Okay.
They lose a lot of their elastic fibers in the wall, and that makes them more vulnerable to increase in size,
Okay.
to develop weak areas and increase in size. Male patients are more likely than female patients to develop this condition, although with the improved survival that we have witnessed in recent years for both males and females, what we have seen is that it tends to appear later in females. So as our population lives longer, female patients show a tendency to catch up in number of aneurysms
really?
in later years
Okay.
compared to the male patients.
Okay.
The number one risk factor is smoking.
Really?
Patients that have a history of smoking, and worse, when they're current smokers, that are at much higher risk of developing an aneurysm.
What is it about smoking? Is there
It is the smoking attacks the wall of our blood vessels, and in
Okay.
certain areas it can create narrowing. In other areas it can create this disruptive anatomy that leads to aneurysm to degeneration of the wall, essentially an aneurysm formation.
Okay.
Patients that have family members, first-degree relatives, that had an aneurysm or were treated for an aneurysm are much more likely to develop an aneurysm in their lifetime
Really?
compared to the other population.
Okay.
So those two risk factors, smoking and family history, are the most important ones.
Okay.
If you have a combination of the two, the chances of developing an aneurysm compared to a patient that has neither of the two is 10 times higher.
10 times. Wow.
Other risk factors include high cholesterol, high blood pressure, and the classic risk factors for developing what we call atherosclerotic or heart disease, peripheral arterial disease.
Okay.
All of these conditions are sharing a large number of these risk factors.
Really? Okay. So turning 60, smoking, family history, a male or earlier on in life, although women have to be concerned about it as well, and then also other arterial disease issues are important. Any symptoms? I mean, you said that symptoms, typically not symptom, but are there any signs and symptoms that maybe somebody can be somewhat alerted to early on?
Unfortunately not. What we're trying to educate patients on is to be able to identify their own risk profile. Okay. Essentially, to realize that if they have some of these characteristics, they are at increased risk for developing these type of conditions. And that should prompt an evaluation by their primary care doctor or through a screening program to try and identify if they do or not harbor the disease.
Okay. And I want to talk to you about the screening and how that's done, but also just a thought on if somebody has some of those risk factors, is there anything they can do, to minimize the risk or
absolutely.
at least lessen it?
Absolutely. Eliminating those risk factors is one of the strategies that we suggest early on, particularly for states of the disease that are very early. For example, a small aneurysm that we detected either through a test that the patient had or through a screening program that does not qualify for elective treatment. If we eliminate the risk factors that contributed to its development, has a lesser chance of progressing to a size that will require elective repair compared to if you continue on your previous life pattern.
Okay.
So going to smoking, which is particularly the one that we're interested in, patients who quit smoking after they're offered a diagnosis or for a different reason, they show a progression on the size of their aneurysm, which is significantly slower compared to the progression in patients that continue smoking despite the diagnosis.
Is there any chance it can shrink and go away by itself, or is that unlikely?
There were some efforts in the past to treat aneurysms with medications that would slow progression or halt progression,
Right.
but we have not been particularly successful with that.
Okay. So let's talk a little bit about then the treatment options and for people that are diagnosed. And it almost sounds like it's, well, before actually I talk about the treatment options, I want to talk about the screening because it seems like it's almost accidental that we find out that people have aneurysms. Let's say I'm over 60, I'm a smoker, I've got a family history. Can I go get screened for it? Is there something I can do just to find out if I've got this or not? And what is that screening consist of?
Absolutely. There's a lot of screening programs. We, as a group, have been offering to the public free screening programs at Stony Brook for the past 5 or 6 years. And as of this year, we started offering these programs here at Southampton Hospital as well. We have successfully performed our first 2 screening sessions here, and we intend to continue on that pattern.
That's great.
The screening is a very simple process. It lasts about 15 minutes, and it consists for the abdominal aorta of an ultrasound that looks at the abdominal aorta and measures the size at 2 different spots.
Okay.
Because of the interrelationship of aortic aneurysms with other vascular conditions, we also check these patients for carotid artery disease that can predispose to strokes and peripheral arterial disease that can really result in from anywhere from inability to walk to limb loss if it progresses in severe forms. The whole process, as I said, takes about 15 minutes. The patients get a complete report about the findings. The primary care physician gets a complete report about the findings. And the idea behind it is to identify these conditions at an early stage, do the early interventions to decrease the risk factors, and try and halt the process from progression as early as possible.
Okay. And if the screening, when you said we take a look, how is that done? I mean, what kind of equipment is it? Does it hurt?
It
That's
does
the
not
question
hurt at
people
all.
always ask me.
It's a sonogram. It's essentially an imaging probe with
Okay.
some gel that goes in the abdomen and in the carotid arteries to
Okay.
look for an aneurysm in the abdomen or for plaque in the carotid arteries.
Right.
And then for peripheral arterial disease, we do a test that is called an ABI. Essentially, we compare the blood pressure to the lower extremities to the blood pressure in the arms, and we try to identify discrepancies in the blood flow between the arms and the legs.
Does it involve radiation exposure at all, the test that's done? Or?
It does not. Ultrasound is a very safe test.
Okay, and I think what most people are familiar with, they see the pictures of the baby getting the ultrasound inside the mother, right? So
Correct. That is very similar to that.
Right, so it doesn't hurt and relatively easy. And how accurate is it? Does it actually do a good job at finding?
It does have some variability in terms of who is the person who's performing the study, but we
Okay.
have very experienced sonographers that participate
Right.
on these studies that give us very accurate determinations on the size of the
So having
aneurysm.
people that know what they're doing is probably the best bet.
It is
So
correct. That is correct.
Somebody's treated or identified, they've gone through, they've been screened, and, well, actually, another screening question. If I've been screened once, is there recommendations for being screened again, or how good is the screen? How long is the screening good for?
I think it's a great question.
Right.
First, let me backtrack a little bit and say that we don't screen everybody because
Okay.
people who don't fit the appropriate risk profile, they probably don't need to be screened.
Right.
But for people who fit the appropriate risk profile, if they're completely normal, they don't need to have another screening for about 10 years.
Okay.
If there are findings that suggest a mild form of disease, either in the aorta or in the carotid arteries, then we suggest that they get screened again in a 5-year period.
Okay.
If, however, we find conditions that are beyond the mild stage, they're moderately severe or severe, then these patients are being placed on a routine follow-up protocol that may be anywhere from annual to every 6 months, depending on the size of the aneurysm and depending on the severity of the carotid stenosis that we detect during that time.
Okay. So you find somebody with an aortic aneurysm or this ballooning of the aorta. What are the treatment options?
80% of the patients nowadays get treated with endovascular techniques.
Okay.
Essentially, we're placing a stent inside the aorta. The stent is a combination of metal and fabric that creates a new lining inside the aorta that protects the weak part from exposure to the blood pressure.
Okay.
The other 20% that does not have the appropriate anatomy is treated with the traditional open repair techniques. The trend is towards a higher percentage of patients being treated with endovascular techniques every year. And that's a function of improvements in technology, but also development of new techniques and development of expertise by the treating physicians so that more complex anatomies can be successfully dealt with using endovascular techniques.
Are there parts of the aorta is a fairly long vessel? Are there parts of it where an aneurysm may be more likely to happen, and are areas that are a little more difficult to operate on?
Both.
Okay.
The abdominal aorta is definitely the site that it is more vulnerable to development of aneurysms.
Okay.
And the majority of the aneurysms form in that area. We have more complex procedures that are aiming to treat aneurysms in the areas where the visceral vessels come off, the arteries to the kidneys, the artery to the intestines, the artery that feeds the liver and the spleen. All of these arteries are very important vessels, and we need to maintain blood flow to them. So when we treat an aneurysm that involves these areas nowadays, we may want to use some more sophisticated grafts. Some of them are custom made to the patient to not only treat the aneurysm, but as I said, to maintain perfusion, blood flow to these organs. We're now testing techniques to treat aneurysms that involve the part of the aorta where the vessels to the head and neck are coming off. And those are important vessels as they can predispose to stroke. We have some early successes with some new technology in these areas, but this right now is the new frontier.
And are you doing, I know you're doing it, but you're doing some of that research here on Long Island at Stony Brook.
We're doing definitely a lot of the most advanced interventions when it comes to aortic disease in this area. And we are part of a lot of the new trials with new devices. So essentially we have technology in our hands that may not be available to other people in the country until it is thoroughly tested and proven of its efficacy.
Right. And I know one more question that some of the other diseases that you are screening for, can you briefly describe what can be done for those carotid artery disease or the peripheral vascular disease, a disease particularly I hear about people losing circulation to their legs. So.
Sure, and those are fairly common conditions.
Right.
I would say they're definitely more common than the aneurysms themselves. Right. Carotid disease is responsible for about 30% of all strokes. So when we identify narrowing essentially of the carotid arteries that exceeds a specific percentage, or when we have patients with narrowing the carotid arteries that come to us with a mini stroke or with a smaller size stroke, these patients require treatment of the carotid arteries. There's two different ways of dealing with that. It's open cleaning essentially of the artery or putting a stent into that area. Okay. We're not yet with the stent technology to the point that we can say safely that it can match the results of an open procedure, but for specific patients that may have other risks, that may be the best solution.
Okay.
So having the ability to perform both of these procedures becomes a great tool in terms of managing each individual patient based on their needs. For peripheral arterial disease, the option of having bypass surgery using either the patient's own vein or an artificial graft is always there for treating extensive disease. But for the majority of the patients, endovascular techniques, either with the balloon angioplasty or using medicated balloons or putting stents into that area, or even more recently, removing some of the blockage by using the devices that deal with that. That procedure is called atherectomy, can give us a number of tools, so to speak, to treat each individual patient and each individual problem with the best possible outcomes.
That's wonderful. So it really is a broad array of diseases and conditions that we're able to treat here. And we are out of time, unfortunately, but I know Dr. Tassiopoulos, I'd like to give a shout out. We'd love to have you here full time, but you're doing a lot of things. So you've been able to recruit. You want to mention your associate who's you've recruited full time to our community, who's working with you here.
We have a big team at Stony Brook,
Right.
but we have a dedicated person at Southampton Hospital, Dr. George Koulias, who is fully trained in both vascular and cardiothoracic surgery. So he has extensive experience in both of these conditions.
And handpicked by you, I would say, to come join us here as well.
He was one of our trainees
Right.
from our fellowship program at Stony Brook 3 years ago, and he is fully trained and fully capable of performing all of these procedures.
That's great. I also would like to give a shout out to our donors, Audrey and Martin Bruce, who made all of this possible for us in the center, and it was a really, really wonderful gift that they made and a vast improvement in care that we're seeing here at the community.
That is very commendable, because what they have done is that they have enabled this type of care to happen right here at Southampton Hospital, because it's not very common that a hospital of Southampton size will have this type of advanced technology. So we should all be very thankful to them.
Absolutely. And given travel distances out here, it certainly is important to have that care as close to home as possible.
Absolutely.
We are so lucky that you've joined us here, and thank you for your guidance, your support, and your expertise. And we look forward to many, many years of you continuing to improve healthcare services here, Dr. Tassiopoulos.
Thank you very much.
And for all of you who may be interested in learning more about Dr. Tassiopoulos, Dr. Koulias, and the programs they offer, or the programs at Southampton, they are seeing patients both in Hampton Bays and at the Schenck Building, our surgical specialty services right here on our campus. I know that the number will be displayed at Meeting House Lane on how to schedule an appointment with either Dr. Koulias or Dr. Tassiopoulos. I'd like to thank all of you for listening, and of course, if you are watching us today, if any of you have questions, would like help navigating the healthcare system here in the East End, please feel free to call my office at 631-726-8555. As always, I'd like to thank our friends at CTV for producing this show and airing it in Southampton. I'd like to thank our friends at LTV for airing the program in our communities in East Hampton, and our medical staff and our new partner, Stony Brook University Medical Center, for the assistance they've been providing. Thank you all. Please call us with any ideas or questions. Good health, everyone.